So Jan assures me that you're all confident with the Ssris and Clark model, so I'm not going to go through it in too much detail, but I thought I'd just do a very quick refresher just to get your minds back in the model. So the reason we're doing it is obviously because we're following the NICE guidelines, and the NICE guidelines for PTSD suggest that everyone with PTSD, even multiple, early life, complicated, complex, whatever you call it, should be offered trauma-focused CBT or EMDR as a first-line intervention. We shouldn't be offering drugs, and we shouldn't be offering non-trauma focused treatments. That's the NICE guidance at the moment. You might be aware that the NICE guidelines are in the process of being rewritten for PTSD, and the new guidelines will probably be out very shortly. In fact, they're out for consultation already, so you're welcome to have a look at them online now. I think consultation documents available, but they're basically actually saying the same thing. The next lot is still going to be trauma-focused CBT and EMDR. Okay. In terms of trauma-focused CBT, we can kind of broadly break it down into two major models. The prolonged exposure model, which is most popular in the States. They do tons of exposure stuff out there, which is Edna Foa's model. And the cognitive therapy model, the Ssris and Clark model, which is the one that we probably use more commonly over here in the UK. They've got loads in common, and actually over time they've sort of drifted closer to each other. I think there's much more cognitive work in prolonged exposure nowadays than there used to be. It used to be just literally reliving, and nowadays you also do kind of cognitive updates, reframes, some elements of reclaiming your life and so on. So the models actually look quite similar now, but the rationale is a little bit different. The prolonged exposure rationale is that we're habituating people to the anxiety that the trauma memory causes. And in the cognitive therapy model, we're trying to make sense of the idiosyncratic personal meanings that someone's taken from the traumatic experience. So they're subtly different. Do people use prolonged exposure at all here? Some of you do? Yeah. And then obviously EMDR is the other NICE guideline recommended therapy. We're not going to talk too much about that today, but those of you who are EMDR therapists, you'll probably also see some of the overlaps between what you do there and kind of stuff we'll be talking about. There's pretty consistent evidence for psychological therapies with PTSD with fairly decent effect sizes. The reason that I predominantly use the Ssris and Clark model is because it's got some of the highest effect sizes in the field. So it's done well, probably the most effective treatment for PTSD as far as we're currently aware, but obviously the data is coming out all the time around this, and there are lots of effectiveness trials going on, but this is from a kind of recent meta-analysis. See the bottom of my slide? Yeah, you might not be able to see the very bottom line of most of my slides, but that's all right. They'll all be on the Google Drive. Okay, so cognitive models, which are what we're going to be focusing on today, predominantly focus on sort of two aspects of the way that the trauma is processed. The idea is that it's processed in a way that leads to a sense of current and ongoing threat due to kind of excessively negative appraisals of what happened or the sequelae. So all that means is that if something bad has happened to me, the sense that I've made of it is making me still feel under threat because I've thought I didn't handle that very well, and that means I can't cope with other future situations, or the world's more dangerous than I realised, or people I thought I could trust, it turns out I can't trust, and maybe that means something about me, or maybe that means something about other people. What the model also says is that the memory hasn't been processed very well. So our normal autobiographical memory system, where things get laid down and they feel like they're in the past, that hasn't happened. There's been some kind of disruption in that normal process, and as a result the memory is very easily triggered, so it hasn't been properly put in the past. All familiar so far? So you might recognise the model then. Looks like this, yes? Good. So again, it's really just saying that the sense of current threat, which is central to PTSD, is caused by those appraisals that people have made of the trauma, and the trauma memory not being very well processed and easily triggered. And that people start doing things to cope with the sense of current threat and to cope with the memory. And those things might include avoidance, trying to keep it out of their mind, or trying to stay away from situations which now feel unsafe. It might mean excessive kind of safety behaviours, checking, scanning for danger and so on. And those behaviours inadvertently have the function of maintaining a sense of current threat. I I don't know if you've ever tried this with a client, but if you go about and start scanning for danger, it does make you feel more on edge just straight away. If we try and push something out of our mind, like we do when we do the kind of thought suppression experiment, you know, like the green rabbit or the white bear or whatever coloured animal we want to use, you'll notice that it comes back. It will come back even more. There's that kind of rebound effect immediately from avoidance. So, and longer term, avoiding the trauma memory means that it doesn't get processed. So that fragmented memory doesn't get further laid down in our autobiographical memory. And also the avoidance and the safety behaviours mean that we never test it out. We never test out our beliefs about something bad happening. All familiar to people? Yeah? I don't know. Are there any more chairs? One here at the back. So, what we're doing in treatment when we treat PTSD using cognitive therapy is a few major things. We need to elaborate the trauma memory so that it gets put in our memory system and doesn't get triggered off. And we need to work out what those appraisals are that people have made of the trauma and modify them where they're excessively negative. Where we find behaviours that are inadvertently keeping the problem going, that are keeping it stuck, we need to help identify them and then help people to give them up. And then where there are triggers which are kind of leading the memory to be easily triggered through intrusions and so on, flashbacks, we need to do sort of trigger discrimination work so that they stop getting triggered off. Is that making sense to everyone? Familiar? Yeah. Good. Okay. So this is what I've just said. Those are the things we need to do. And usually the course of therapy looks a bit like this. Now, because cognitive therapy isn't a protocolized treatment, there isn't like a session 1 do this, session 2 do that, session 3 do the other. It's a formulation-derived approach. Okay. So each person you treat will probably look slightly different in terms of the order that you're doing things. Yeah. But usually it has these key elements in it. Usually at the start you'll do some psychoeducation, help people get a bit of an understanding of what's going on and create kind of shared formulation, a shared understanding of where the problem came from and what keeps it going. And you'd usually start off early in treatment with some kind of reclaiming your life activities, getting people back into the things that they used to enjoy, used to give them value and meaning, which they're not doing anymore. Generally, where possible, you start the memory work as early as possible, as early as session 2. Very often, when we do intensive treatments, you might be doing reliving by the end of the first day. You know, the memory work is really crucial in cognitive therapy. And that involves predominantly something like imaginal reliving or written narratives about the trauma. But then, unlike prolonged exposure, where that's the main focus of every session, in cognitive therapy you might only do that once or twice, because you move very quickly on to identifying hotspots, updating hotspots, which involves bringing new meanings back into the trauma memory. The other kind of key bit of memory work is usually stimulus discrimination. So that's the triggers work that I was talking about before. And then what you will also be doing is cognitive work. Now the cognitive work and the memory work go hand in hand in cognitive therapy. So you might do a bit of reliving, and then you might identify a hotspot and do some cognitive work on the hotspot. Then you might bring that back into the memory work and do some more reliving with your updates in there. So it's not like sequential, you kind of go backwards and forwards between the memory work and the cognitive work. But with the cognitive work, you're addressing the kind of key meanings, those key appraisals. And they might be things which happened at the time of the trauma. So it might be that in the middle of the trauma, I thought, you know, I'm going to die and this is all my fault. And that I would need, therefore, to update that meaning that's associated with the trauma memory. Or it might be things that have developed since the trauma. So it might be that it's only since the trauma that I've started to feel that I can't trust people or that I'm more unsafe. So you might be doing some cognitive work about beliefs that I have sort of outside of the trauma memory, or you might be doing some which you bring back into the trauma memory. And then usually towards the end of treatment, you would start doing things like revisiting the scene of the trauma, doing a site visit, and then you start doing kind of consolidation work to make sure that everything is in place, and relapse prevention work. Okay. And as I say, these two bits kind of go backwards and forwards between each other. Also, you might, in some cases, do some cognitive work before you do some memory work. For example, if someone has got a trauma memory where there's a lot of shame and they can't tell you about it yet, they can't talk about what happened, it might be that you need to do a bit of work around the meanings attached to the memory just to free them up to be able to tell you what happened. And we'll talk about this a bit later, it might be that they are very dissociative and they're going to struggle to kind of do memory work straight away. So you might need to put some things in place before you move into the reliving. But those are sort of some of the more complexities that we'll talk about. Making sense so far? Yeah. Any questions? Are there any bits of this kind of treatment art that people kind of aren't familiar with, maybe haven't done before, want any more info on?
The only bit that sort of surprises me is actually how soon you're talking about doing the reliving. I think I'm guilty of delaying that a little bit.
Yeah, people do very often actually, yeah.
And the rationale for starting it earlier
is that it's important and you might as well get on with it.
Straight to the point, aren't they?
Yeah, no, but in all seriousness, like, I think a lot of therapists, and probably especially when I have kind of more junior therapists that I'm supervising, they spend a lot of time kind of building up to the reliving, you know. So, and they might do like a whole session preparing their client for it, and then they say, oh, we haven't got time this week, so we'll do it next week, you know. And then the client's got a whole week to worry about it, basically. And I don't think it always needs to be kind of built up to that extent, both for your anxiety as a therapist and for your clients. I think if it's just a kind of a very normal thing to introduce very early on, a lot of clients are kind of fine with that, you know, because you've probably already talked a little bit about what happened during the trauma, either in the assessment or in your first session. So it can be quite easy to just say, okay, so what I'd like to do this week is talk a bit more about what happened, but we're going to do it in a slightly different way this time. You know, this time I want you to kind of talk me through it step by step and bring it to mind, so almost as if you can kind of see it again. And a lot of people are okay with that. I mean, as I say, there are cases where you wouldn't do that. For example, if someone was risky, if someone was dissociative, if there are a lot of complicated meanings attached that are going to make it very hard for them to talk it through. If the trauma memory is very patchy, then you might want to map it out first using like a timeline or something. These are cases that we're going to talk about in more detail today. But yeah, in a lot of cases, why not get on with it, I think.
I feel like a lot of people I work with, the functioning is so low that they need to sort of do almost like, you know, BA for succession, supposed to be training to kind of get them out of the house, to get them so that we see other people or doing other things, because I feel like that's a really important foundation for reliving.
Yeah. When you say their functioning's low, what kind of thing do you mean?
Well, I suppose very often people completely stop engaging with things that are the barriers, with the kind of not doing things that are important to them. And I think when I'm done reliving with people that are at that point, I tend to do more reclaiming, so I tend to do 4 sessions of reclaiming.
Right, yeah. I think the difficulty can be that if someone's functioning has really reduced because of the PTSD, you know, so part of the reason they're not doing very much is just because they get a lot of intrusions when they're out and about, for example. Actually getting on with the trauma-focused work frees them up to do more. However, if someone is so depressed that they're hardly getting out of bed in the morning, they've got absolutely no social support, they've got a lot of kind of life problems, and that's likely to create any kind of risk and so on, I probably wouldn't jump into reliving. I'd probably spend a little bit more time sort of getting them going, getting stabilisation going, which I'll talk about. But if there's not much risk and it's their symptoms that are keeping them on the floor, actually treating the PTSD is going to be the most effective thing to be able to get them up and going. So yeah, I might move ahead even if someone's not got pretty limited functioning. Yeah.
If you're aware of kind of substantial guilt or shame, might you start there first rather than
So I would usually, if someone is allowing me to, and if we've got the therapeutic relationship to do it, I would usually still do some reliving even when there's high guilt or shame, but I would move much more quickly into cognitive restructuring work, working on the hotspots, but sometimes what you get, as I say, is people where they've got very high guilt and shame, they can't yet talk about it, and you're going to threaten the therapeutic alliance, because the most important thing is that people keep coming back, right? So if someone's very ashamed of something, I wouldn't push hard on the trauma memory if that's making them feel really bad straight away, because I need them to keep coming. So we might need to spend a bit more time building the alliance, working on the shame, working on more of the kind of stabilisation aspects.
I'm quite reassured to hear you say, because I think I get on with it quite early.
Yeah.
And part of me thinks, is this something I'm not doing before?
Yeah. I mean, I'll talk a bit about stabilisation in a minute and the whole kind of debate around stabilisation, because it's quite controversial at the moment within the kind of PTSD community, like how much you should be doing stabilisation, especially for kind of more complex presentations.
And it's a message we often get from tertiary care about, well, can you just do some stabilisation first? And
Right.
on its own, stabilisation isn't an actual mention, so that
No.
stuck.
Yeah, okay.
That'd be
Yeah.
interesting.
Yeah, we can think about that at a service level as well.
I was just going to ask, in terms of homework, I sometimes feel a bit concerned about giving people sort of reliving type homework. So, for example, listening to video recordings and then talking about school and things like that.
Yeah.
Is that something that, what do you
What would your concerns be?
just that they're on their own with it,
Yeah.
and that they're experiencing flashbacks and they're really struggling, and that there's another week before our next session.
Yeah. I mean, if they're experiencing flashbacks, then no, because that's not helpful for anybody. And if the reliving has triggered them to have a flashback in the session, I wouldn't be listening to it for homework. I'll be teaching them to ground themselves and setting that for homework to practice that. For a lot of people, reliving isn't as bad as they think it's going to be, especially if you've kept them in that therapeutic window. And so I think if it's gone okay in session, I usually say to people, how would you feel about listening to this back? I'm assuming people generally record sessions and ask people to listen to them for homework now. Is that fairly standard?
I do a lot of writing.
Writing, yeah. I mean, nowadays, smartphones, most of our clients have them. Most of them have a voice recorder function. It's much easier than it used to be. We used to be faffing around with like tapes and burning CDs and things like that for people to take a session recording home. Now you can just kind of get into the practice of them recording the session and then listening to back afterwards, because people only take so much in at the time, obviously. So I think there are situations where I might not set listening to a reliving recording as homework. If it hasn't gone very well, again, if I'm concerned about risk or dissociation or anything like that. But for the most part, if it's gone okay and the person seems kind of okay with it, I would often have the chat about, it would really be a kind of a good step forward to go through this a few more times. Would you be alright to listen to it over the week? A lot of people say yes. Sometimes, so the Ehlers and Clark group, for whom I work now, so full disclosure, they used to focus very much on reliving and not much on writing. But nowadays they use them much more closely, much more equally, because they find that written narratives seem to work as much as spoken ones. So sometimes what I get people to do for homework, if we've done a imaginary reliving a spoken one, I might get them to do a written narrative for homework and vice versa, potentially. We'll talk in a minute as well about why you might do written narratives as opposed to imaginary reliving, because they can be a little bit less immersive. Okay, any other questions about the kind of basic elements of CT? Quite familiar? Has everyone had a go at this? Has everyone treated a few? Right. Okay, so let's talk a bit about complexity then. I think it's kind of an interesting term because it gets bandied around a lot, and I think people aren't completely sure what they mean by it, or they might be sure what they mean by it, but it might be different to what someone else means by it. I think there are probably a few different aspects of complexity in PTSD that we need to kind of think about. One is where someone's had more than one traumatic experience. Another is comorbidity, where there are other disorders that might be sort of overlapping with or interfering with the PTSD. Then we see a lot of people with PTSD who also have significant social comorbidity, social problems, risk, where there are kind of significant problems forming a therapeutic relationship, where it's really difficult to engage someone or to gain someone's trust. And then dissociation is a thing that people often worry about, and is a common kind of associated feature of PTSD. And then I think another kind of common issue can be where there are kind of gaps in the trauma memory. So where people, for example, might have taken a knock to the head, they might have been under the influence of something at the time, or like a drug-assisted rape, or just where they were dissociated and the memory is just very patchy. I think they can be harder to work with clinically as well. So these are kind of what I see as kind of common types of complexity when you're working with PTSD, and the sorts of things you might come across, I think, in your practice. Is that fair to say? Mm-hmm. Yeah? Okay. I mean, I steer away from the term complex PTSD in general, because until recently it hasn't really been a diagnosis, and it still isn't in DSM-5. But you might be aware ICD-11 has recently introduced the diagnosis of complex PTSD. And what complex PTSD is, according to ICD-11, is PTSD plus some associated features. And those associated features are affect regulation issues, problems forming interpersonal relationships, and sort of strong negative affect and cognition, so long-held beliefs like low self-esteem and those kind of things. And I think, to me, complex PTSD and PTSD are probably on a bit of a continuum. I don't know how you guys feel. It doesn't feel to me like it's a whole separate problem. You know, there's a huge amount of overlap. And a lot of the people we might see who have kind of so-called like straightforward PTSD might also have a bit of an issue with forming relationships or with their emotions and so on.
It's useful for us because it helps with the pathway.
All right. The complex PTSD diagnosis. Okay, so are you using it in your trust?
It's just in between in the interface between step 3 and step 4. So.
Okay. So in theory, you won't be seeing complex PTSD cases. Is that right?
In theory.
In theory.
Yeah.
Those kinds.
But I guess
Yeah.
when you're thinking about that continuum, I think that really sort of fits, doesn't it? Because it's those that fall maybe in the middle because of that continuum that
Yeah.
we maybe need.
I think
Yeah.
we would see people with all of the characteristics that we've discussed.
Yeah. It's going to be interesting to know where the line is going to get drawn and who's going to make that call, I guess, as well. Yeah. Are they going to use the ICD-11 diagnosis? Like, are they going to properly diagnose it? Or is it just going to be someone's going to say, this sounds like complex PTSD, right? Yeah, that may or may not go well. Okay. Well, I think this is something that's happening a lot in IAPT and other kind of service provision territories, because, as you probably know, the range of what IAPT is expected to see has sort of gradually sort of drifted, hasn't it, outwards, so that it's kind of a bit of everything now. Anyway, well, we'll talk about these kind of complexities today. As I say, I think a lot of what I'll talk about would also be relevant to kind of complex PTSD, but I think the people who are sort of somewhere in the grey area as well will probably be the types that we'll have to think about. Okay. So to my mind, I kind of see it all through the lens still of the model, okay? So I don't think it's like when there are these things present, you need to chuck out everything you know about treating PTSD and about cognitive therapy. I think we can situate most of these types of issues still within the formulation. So for example, there might be some things to do with the kind of the characteristics of the trauma or people's prior beliefs and so on, which are causing, for example, a problem in forming a therapeutic relationship, like someone who's got a very long history of being unable to rely on caregivers, for example. It might be that you are thinking about sort of the appraisals of the trauma through this lens as well. So, for example, when you've got someone who's had multiple traumatic experiences, it might be that by the time another trauma has happened, they're thinking, well, this is the third thing that's happened to me, so there must be something about me that this keeps happening, or something like that. Okay, so the areas of complexity that I thought we could talk about today sort of come from this as well. So I think, first of all, this morning, I thought it would be good to talk a bit about kind of making therapy safe and thinking a bit about what's possible in therapy, when you treat PTSD, when you don't, when you move into memory work, when you don't. And within that, we can think a bit about kind of IAPT as well, and where you draw the line as a service or services. And then I think, assuming we are kind of taking the cases on, we'll kind of cover these areas. So what you do when you've got someone who's got quite risky coping, because I think that's an area of complexity that causes some anxiety and needs to be treated carefully. And then we'll talk a bit about kind of how you adapt memory work when there is some kind of complexity there, and also about how you kind of enhance your cognitive work. For example, if you've got very sticky beliefs that are hard to shift, very long-standing beliefs, that kind of thing. Is that sounding all right? Are these the kind of things people get stuck on? Yeah, me too. And we won't have all of the answers, obviously, but we'll be able to kind of talk them through. But anyway, okay. And a lot of this is about flexibility. Okay, a lot of working with complexity is flexibility, because if we try and stick rigidly to a protocol, bang, 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 we're going to lose people along the way. There are some people who aren't going to be able to do the exact elements of the treatment. If you've got a kind of a very straightforward, simple instant adult trauma, the kind of things that IAPT was supposed to be treating, you can probably follow those steps through that I mentioned earlier with very, very few kind of trip-ups. But with someone where there are some complexities going on, you're going to kind of lose them, or your therapy is going to be less effective unless you're flexible. And also you might recognise this from Nick Gray and Adrian Whittington's book, if anyone's read it, about metacompetence in PTSD, metacompetence in CBT. But there's an idea that it's possible to be kind of tight to your principles and a bit looser with your techniques and your tactics. So some of what we'll talk about today is about kind of how you flex, how you sort of make things adapted to an individual. And that's sort of what metacompetence kind of is. Because there's a danger that if we kind of lose track of our principles, so if we lose the model, if we don't know what process we're working on, because I think you should always kind of know where you are in your formulation a little bit, kind of why you're doing what you're doing, then there's a possibility that you'll sort of, where am I? Here. So if you've lost your principles, you can get into a bit of kind of unfocused practice, where you're not quite sure what you're doing and why you're doing it. If you've kind of, but if you're still trying to bang away at the same things and you don't know why you're doing them, that's when you kind of get into this very rigid, unhelpful practice. So an example of that might be just sort of using the classic reliving with someone where actually they're struggling to engage with that. We just kind of keep doing it, and we're going to lose people. It's not effective. You can be kind of very adherent to your model if you're tight to both your techniques and also your principles. But with those more complex cases, that can be harder to do. You might not be able to do it kind of in the sort of textbook way. So this is where we're going to be kind of aiming for today, which is being kind of tight to the principles, knowing why we're doing everything, following the model, but at the same time a bit more flexible and hopefully a bit more creative in the way that you apply the therapy. And I actually really like this kind of work. Like, I like working with complex cases because it does give you a chance to be a bit more kind of thoughtful and inventive and to do some slightly interesting things rather than just kind of following a protocol through. Is that sounding okay? Does anyone feel like they're currently metacompetent? I think in IAPT you actually kind of have to be metacompetent because you're treating so many different problems every week and so many different models. You've got a lot of things in your brain that you can apply. So I think it's hard not to be metacompetent in there. Okay, so let's talk about the first area of complexity, which is kind of how to make therapy safe. So are people aware of the kind of phase model, Judith Herman's model? Yeah. So she came up with this quite a while ago, which was the idea that when you've got a kind of complex PTSD case, you should stabilise people first in the first phase of work, then you move on to trauma-focused therapy, and then in the final phase of treatment you're kind of reintegrating them. You're getting them back out there to do the things that they weren't doing before. Okay. However, and for years, I think most of us working with complexity have been going, yeah, three phases, stabilise first, blah, blah, blah. There's actually quite a debate going on because there's very little evidence that stabilisation A works and B is necessary for the vast majority of people, even people with so-called complex cases, complex PTSD. And this came out quite recently. I'll put it in your Google Drive by Adi De Jong. And basically they kind of reviewed all of the literature on the stabilisation phase in complex PTSD and basically sort of said it's not based on anything, like we don't know if the stabilisation phase is necessary or not. It's all come from kind of best practice guidelines and, you know, experts by consensus, as they see. But the trouble with experts by consensus is we all sit around and tell each other what we think, and if someone agrees with you, go, oh, okay, then we've got a consensus, so that must be right. But actually it turns out it might be one of those assumptions that hasn't been questioned critically in terms of the research finding. And there's quite a few, sorry, this projector's not great, so you might not be able to read these, but I'll explain what they are. There's recently been quite a few studies where they've taken the stabilisation phase out, or they've compared interventions where there's stabilisation. So for example, this one that's happened in the Netherlands recently by Sandra Raab, they compared stabilisation and then imagery rescripting with just imagery rescripting with people with childhood abuse histories, with PTSD to childhood abuse. And the stabilisation phase didn't add anything, basically. The people with the imagery rescripting immediately did as well, and they got better faster, and they needed fewer sessions than the people who had the stabilisation first. So it's quite sort of debated at the moment whether this is actually needed. And as I say, these are quite complex cases that some people are treating. However, and I've spoken to Sandra Raab about this, I said, you know, were you excluding people for any basis? You know, for example, if they're very risky. And she said, well, yes, people with immediate risk wouldn't have been in the trial, right? You know, and I said, well, were you treating people who have borderline personality disorder as part of the trial? Well, no, probably not. Some people did apparently have personality disorders in this trial, but borderline would have been in exclusion criteria. So I think there are some cases where we do need to stabilise, and you have to kind of be a little bit careful, I think, interpreting all of these studies too. So I'll tell you what I think stabilisation can encompass, and when I think you should use it, and you can see how it fits with your experiences as well. So I think sometimes we get people who've got a sort of very significant practical problems. So they don't have a safe place to live, they're currently homeless, for example, or they're about to be kicked out somewhere. They've got a legal case which is getting heard next week or something where, you know, their kids might be getting taken away from them, they might be getting deported from the UK, they are going to have to give evidence against the person who attacked them, whatever. I think where these sort of immediate practical problems are highly preoccupying for our clients, it's very difficult to move straight into trauma-focused work. Having said that, if we never did PTSD treatment with anyone who had social problems, we would be excluding a huge number of people. So I don't think it's a hard and fast rule. What I tend to look for when I'm assessing people is how much is this likely to impact on their ability to engage with treatment. So if there's a legal case that's going to be heard in like 6 months' time, I might think let's just get on with it now, if the person kind of is up for it and feels ready. But if someone is waking up every day, if they're spending loads of time worrying about, you know, the court case or the fact they're going to be kicked out of their house, if that's the main preoccupying feature of their presentation, and you'll know as well where you're treating someone and you're setting your agenda and all they want to talk about is their money problem or their relationship problem or something like that, and you keep saying, well, we're going to do reliving today, but you know, there's something else that's on their mind. You can't just ignore all of that, you know. So I think where there are sort of serious, preoccupying, practical problems, that was a mouthful, then you're going to have to do something about it. And obviously we're not social workers, it might involve kind of directing them to kind of alternative means of getting help and support around this, and then potentially kind of coming back to you when they're ready to go. Sometimes all it takes is like a letter from you or something like that to kind of housing or something, and you can move on to things. So sometimes practical things require stabilisation. The other major thing is obviously risk. So one of the problems with kind of trauma-focused treatments is it can increase risk in the short term. You know, it's possible, not for everyone, but it's possible that some people will have a slight increase in symptoms in the week after you've done some kind of memory work, for example. So we don't do that with people who are at acute and immediate risk. So that, by that I mean they've got plans or intent to harm themselves in the near future. You can't come up with a kind of sufficient safety plan with them. Now, again, if you never did PTSD work with anyone who'd ever had a suicidal thought, you're not going to get very far. So I think there is kind of an assessment that you need to make of sort of what's safe and how far you can push things. Because I also think in the long term, it's unsafe to leave people with PTSD if you see what I mean, if that's a major cause of their risky behaviour. So I think it can be unhelpful to say, oh no, I can't treat you, you're too risky, if actually the PTSD is causing the risk. But what we often have to do is just put some things in place, a good safety plan, some closer monitoring, going very gently into memory work, for example, and checking what influence it has on their symptoms and their risk, and a good trusting therapeutic relationship where they're going to tell you if it's escalating in any way, that kind of thing. Yeah. But you might need to set all of that up. So obviously we think a lot about risk to self. With PTSD we also have to be a bit aware of risk to others, you know, because irritability is one of the criteria, and you might get people who are getting into confrontations, conflicts, stuff at home, stuff out and about if they get into any kind of a situation. And we also have to think a bit about risk from others. So I think especially with PTSD where we've got people who have been attacked or persecuted by someone who is still within their world, if you see what I mean. So very often for us it's women who have been, and men, but predominantly women who have been in violent relationships, and whether there's still any contact with the perpetrator, whether there are kids involved, that kind of thing. If that's the case, we might need to do something to stabilise that risk as well. That might be a case of speaking to the police, working out what they need. The difficulty can be that some people with PTSD overestimate the risk to themselves. Again, that's one of the features of PTSD, and it can be quite hard to work out, you know, if this person is genuinely at risk or if they just feel themselves to be at risk. So often what you need there is kind of hard data. You know, you need to actually get the kind of facts of, for example, when did they last see the perpetrator, when were they last contacted by them, what would they do if they saw them again, you know, these kind of things to really be able to get some clarity in your risk assessment. And drugs and alcohol, we'll talk a bit more about that in a minute. With your services, what's your policy on drugs and alcohol, and when you offer treatment and when you don't? Or is it a grey area?
There is a policy, and we use a severity of dependence score, which is very subjective, so if people don't perceive it as a problem, then they would score very low anyway.
Interesting, yeah.
But if people are using in a way where they can, they're not using daily, or they're not necessarily using to self-medicate, and
Yeah.
it depends in any way.
Yeah.
It's not a blanket no chance.
No, sure. Okay. Yeah, it's interesting. Yeah. I think again there's sort of probably been some changes in the recommendations of treatment with PTSD and drugs and alcohol, because I think I remember a time where we used to say, you know, you're going to have to get clean, or you're going to have to get this alcohol problem treated before we can treat your PTSD, so go and get that sorted and then come back to us, kind of thing. You might have spotted this fundamental flaw potentially in that argument, that, you know, if they are using it in partly to treat their PTSD, then they won't be able to do that, you know. And there are now protocols which are sort of around treating them in tandem. So there's a nice model. I can put some papers in the shared drive for you, by Lisa Navayitz, which is called Seeking Safety, which is a comorbid PTSD and substance misuse kind of protocol, step-by-step protocol, which I think is probably a better way to treat both problems together. And certainly in my team we do treat people who are using both drugs and alcohol, but we would address them very early in treatment. But as you say, we might have rules around kind of dependence, we like people to at least be able to access the treatment when they're not intoxicated, so they need to be able to say that they can come and have at least a day off from whatever they're using to be able to access the treatment. But I think we've sort of become less strict, interestingly, over time, just because of that problem of then, people getting stuck in that catch-22.
Can I just ask, when you said that you might make that decision but encourage them to seek help around it sooner rather than later in treatment, what services would you, are you in your team, have you got people in the team who would work with that, or are you talking about external agencies?
No, I'm not talking about either. I'm talking about us formulating it as part of PTSD, as part of an unhelpful coping strategy associated with PTSD and treating it that way. But I think that would be for people where, for example, they've started drinking or using since the trauma, and they very much see it as a way of coping with their symptoms.
So you'd be looking at encouraging them to self-manage a change there, so looking to
We'd be helping them to do it, yeah. But I think if you've got someone who's got a real history of dependence that predates the trauma, in those cases I would be less likely to do that, because I would think probably that we are going to need some help from external agencies. And then I'd have a conversation with the client about how to manage that. Yeah. I mean, we have previously, and actually this is more from my old team, where we had a significant waiting list, we would talk to people about it, the assessment, and kind of say, and if they were really keen for treatment, we would say, okay, if you can get it down to this amount, by the time you start treatment, then we'll treat you. And if that doesn't work, then we're going to need to get a referral to the drug and alcohol agency. Okay. Then other aspects of stabilisation you might consider is where there is comorbidity that would interfere with treatment being successful. Okay. So with PTSD, as I'm sure you're aware, comorbidity is the norm. Something like 88% of people with PTSD also meet criteria for something else. So we don't not treat people just because they have another disorder. But what we are trying to do in our assessment is work out, is PTSD the main problem? And also, are the person's goals mainly around the PTSD, or are they mainly around something else? Okay. So if you've got someone who also has some psychotic symptoms, severe depression, a personality disorder, you might still treat the PTSD if the PTSD is the main problem, and if the symptoms of the other problem wouldn't interfere with your ability to do the work. But if the other problem seems like it's their main problem at the moment, their goals are around, for example, improving their mood, or it would interfere like because of risk, or because they're not going to be able to get to appointments, or because they kind of lack the concentration ability to get through a session and those kind of things in the case of severe depression, you might need to think about helping them access some treatment for that before you move into the PTSD work. That kind of makes sense to people? Is that your rule of thumb a bit as well? Main problem, goals?
Yeah, we have a bit of a thing where, so we try to refer around and people say, well, can't you just work on the panic attacks, or can't you just work on the depression?
Yeah.
And when it's not representing
The main problem? Yeah.
I have an issue with that even being ethical.
Yeah. I mean, I think it comes down to client choice then as well.
Yeah.
And I have sometimes done assessments with people where I thought something is the main problem and someone else, and the client said to me, well, yeah, that is a problem, but what I want to work on is this, because I'm really distressed by this particular symptom. And it might be that you can do that within the kind of the formulation, but it might be that you can't. Okay. Other stabilisation aspects I think you might need to bring in if someone's got an ongoing medical problem that isn't being treated sufficiently, if they are using high levels of medication, and I think especially with PTSD, we sometimes get people referred to us who are on very high levels of benzodiazepines or very high levels of opiate-based pain medication. Like, has anyone ever taken tramadol or a kind of morphine-based medication? Do you know how it makes you feel? Yeah, like you've got a duvet over your head or something. Imagine trying to do PTSD work with someone where they're really taking these heavy-duty medications. And a lot of the people that we see who've got a pain condition get given a lot of these medications. And we find that treatment is just less effective, really, if they're on very high doses.
It's difficult, isn't it, though, because the PTSD could have been caused by a trauma, which has left them with a physical problem which causes the pain.
Absolutely.
People can get stuck in that,
They can.
can't they? Like,
They really can,
they can't
yeah.
get treatment, nothing's going to change anything because some of the pain things might never improve.
Yeah.
If they can't do the PTSD work either.
No. No, and I'm not saying we wouldn't treat people, but I think what you would try to do is have a conversation with whoever's prescribing that, whether it's a pain clinic or whether it's their doctor or whatever, to see if they can get onto a non-opiate pain med, at least temporarily, while you're having your sessions. Because obviously if someone's in a lot of pain in your session, they're also not going to be able to concentrate. That's not helpful. So it's not a case of just saying to someone, "Oh, try not to take your tramadol today," if that's all right, you know. If they can do that and not experience severe pain, then fair enough, but they probably are taking it for a reason. But we might need to try and get people either to cut down, if that's possible, or at least get reviewed by a doctor around it. And the non-opiate pain meds don't seem to have the same effect in terms of the numbing. And I think the reason it interferes is because that bit of the autobiographical memory system that we need to kind of reprocess the memory is part of the brain that's being kind of affected by these drugs. So they can be quite problematic.
I would have thought that the same principle would have applied to long-term drug and alcohol use. The physiological effects on the brain would have left it difficult to process the memory.
Yeah, you're absolutely right, actually. Yeah, and I can't remember, is it Korsakoff syndrome, the one that affects your hippocampus? You know, which can affect memory hugely. Yeah, and the hippocampus is probably the bit that we need to be working here. There's a bit of evidence around people who have dementia and PTSD, very difficult to treat, and I think part of that is because the memory, the bit of the memory system that you need to reprocess the memory is the bit that's really suffering with something like Alzheimer's. Because outcomes, and I've treated maybe 1 or 2 people who have a dementing condition and PTSD, and outcomes are very poor. It's really difficult to get the memory processed. You can do other parts of the work often, but sort of getting rid of intrusions and things can be very tough. So yeah, you're right. I think it probably does impact.
Right.
Yeah.
Just 2 questions really. One about sertraline or high doses of those sorts of antidepressants with an anxiolytic effect. Whether you found them to be problematic in terms of complexity. The other question was going back to your people in chronic pain or on high levels of opiates. What's your kind of plan, solution, decision to treat framework about that? So if they are on a high level of opiates, I mean, do you sort of, well, let's give it a go, or do you?
Yeah, I mean, as I say, with that one, I would try and speak to whoever's prescribing. So if it's the pain clinic or GP or psychiatrist. In fact, if they're not under a pain clinic, I would probably try and get them under a pain clinic. And then I would try to have a conversation with the prescribing doctor and with the client about, is there any alternative to this, even as a temporary measure? And even if you can create a window around your session, like on the day of the appointment and maybe the day after, to use a different medication instead of the, whatever it is, codeine or tramadol or whatever, just to create a bit of a window for the processing. That's what I would aim for with that. And also, to be honest, I think a lot of doctors, I think a lot of the people we have who have chronic pain conditions, they've been prescribed all sorts over the years, you know, because they keep going back and they're still in pain and the doctor gives them something else, and then they're still in pain and they go back and they get given something else. And I think very often people do need a proper medication review, you know, and sometimes you can push it in terms of them getting onto a pain clinic.
So that'd be like a prerequisite before starting treatment, I guess. But I suppose my question was more that if that's not the case,
if that's not possible,
and they don't want to, or would you just say, well, okay, let's give it a go? Or
I'd probably give it a go. Yeah. Don't like to say no to people unless there's a very clear risk reason or something. So I probably wouldn't say no. I might if someone was taking so much that they were just totally numbed out and they were telling me I can't take anything in, I can't recall anything, and you know during a session they're clearly somewhere else. But you're gonna figure that out pretty early on in treatment as well. You know, and if you've done a session and you at the start of the next session you say, so what did you take from last week's session? And they say, who are you? Then you're probably not going to, and that has happened to me, you're probably not going to be able to progress very far in treatment. But yeah, I probably wouldn't say no, but this is just kind of around maximising effectiveness, I'd say. Yeah. And with your question about SSRIs, we haven't had the same problems with those. We have a bit of problem with the benzos, and I think that's often because people might take one before they come to a session, or if we're about to do like a behavioural experiment or something, they might take one, and obviously that limits both the learning that can happen at a physiological brain level, but also the learning that happens in terms of safety behaviours and knowing that. So people who are taking a lot of benzos as well, I would probably speak to them and their doctor about whether there's a way of cutting down on those. And it might be you need to do a bit of a stabilisation phase to teach them alternative ways of managing their anxiety so that they can reduce them. Is this happening to you guys, that you're getting PTSD clients who are already taking quite a few meds?
I've certainly had people, not even thinking of a PTSD client, a chronic pain client actually, who voluntarily said, I'm not going to take it on Monday mornings because I want to be able to think in session. And was prepared to put up with it.
Yeah.
And I've had someone that was due to social anxiety who, about 3 sessions in, were really into behavioural experiments, fessed up, as he put it, to using cannabis almost constantly, so he didn't feel anxious. It's like, you can explain.
I've had PTSD clients turn up to a session, obviously under the drunk alcohol, and you can smell it, and when I've asked them, should I get down the bottle? Beer, fucking, and then I've had somebody, not on PTSD, but a guy in a lot of pain, chronic pain, on tramadol, falling asleep in my session. People are going to struggle just to engage, just to have the capacity to get through your hour or 90-minute session and take stuff in, I think, if they're affected by these things, It's not uncommon.
I think it'd be interesting with what you were talking at the end about the kind of looking after yourself phase. Because I'd say PTSD is probably one of the more upsetting things that I do work-wise anyway. I was just thinking, God, a pain client, if I'd asked them to reduce their opioids and they're in pain as well, so now my sense of I've got to do this right, it's just shocking the roof because they're paying so much more.
That's
interesting, But their pain is such a, the pain is partly a cognitive construction as well, isn't it? So I think there's a rationale, people can get a rationale. Or you can try it with the pain meds and go, oh, we're not making progress.
There's some stuff coming up around pain meds now where they're saying I'm not even sure they're that wonderfully effective, and actually you kind of get off all of them. Actually, they're not that much different.
I have had some clients who've had that experience where we've tried to reduce, we've reduced their meds and they've said it's not making any difference, or that what the meds do is a kind of, doesn't really get rid of the pain, it just makes you a bit more numb to it. But that actually doesn't feel that good, if you know what I mean, that it's not very nice. But, I think all of this stuff probably goes without saying, I'm sure you guys are doing this already, has to be done within like a shared, collaborative therapeutic relationship. We're not telling people get off your trams so that you can come to session or anything like that. We need to talk to people about, this is how we understand PTSD, this is kind of what needs to happen for you to be able to get better, and part of that is going to be around having a clear head. What do we need to do to help you be in a position where you can kind of get the most benefit from this treatment, and kind of problem solving it together, I think. Because hopefully it's not too much of a bargain, if you don't take your pain medication, I'll make you better, I think that places pressure on us and builds a tension into the therapeutic relationship that isn't very healthy, potentially. Okay, so last kind of bits, we're going to talk in a minute a bit about kind of the therapeutic window and sort of around distress tolerance. There might be people who you work with where it's very, very difficult to progress, because as soon as you get near to talking about the trauma, for example, they become extremely distressed to a point where they're having a panic attack, or they're sort of sobbing to an, where you just can't move forward, sort of thing, or where they're at risk of dropping out, they don't want to come back. In those cases, you're going to need to do some stabilisation work, and that might be around things like psychoeducation and grounding. It might be treating panic disorder if the panic disorder is there as well and that's interfering. It might be kind of ways of managing their distress, increasing their distress tolerance, just to kind of widen your therapeutic window a little bit for you to be able to do the memory work. And then sometimes in the stabilisation phase, I might do a bit of symptom management work around sort of associated problems. So things like some sleep hygiene, if someone's sleeping very poorly, some stuff around flashbacks and nightmares, like grounding, stimulus discrimination, and potentially some kind of mood intervention if someone is very low, like BA or something like that. Now, usually I don't want to use too many of my sessions doing this stuff before I get on with treating the PTSD, because when you're on a tight time frame, this stuff should improve if it's all part of the PTSD or secondary to PTSD. It should improve when you successfully treat the PTSD. But there are some cases where I might do this early on, particularly if I think someone's very ambivalent and they might drop out. You know, if you've got someone who, and we get this with PTSD, it's a disorder with one of the highest dropout rates, you know, and that's partly because avoidance is a massive part of the diagnosis. You know, it's tough going. So we have to be very careful that that we've got people engaged properly. So if someone is, you know, we've been doing some kind of psychoed and we're doing some formulation, and someone's saying, oh, I don't like the sound of this, you know, I'm not sure I'm very keen on it, you know, you might say, okay, well, you know, let's first of all then let's have a bit of think about these nightmares you've been having and see if there's anything we can do. Because if you can then kind of build the trust and for them to feel that treatment can be effective for them, you've got a better chance of being able to kind of do the more effective parts of treatment. But as I say, I would rather not focus on this if I can get away with it in terms of too much of the sort of stabilisation phase around symptom management.